I'm here today to speak about the components of a prenatal consultation. As you can see, we are all part of one amazing team, and I'm just a very small part of it. Oops. Okay. I only put in 2 images because I knew Dr. Bornstein was coming with all of his. Oftentimes it starts with an ultrasound, in this case unilateral and bilateral clefts. But now working with Dr. Bornstein here at Lenox Hill, there are many other conditions that can be identified. And maternal fetal medicine will refer the family, or the family will refer themselves to our program, to one of our world-renowned physicians, or through word of mouth. There's so much going on the internet. So once the initial team contact has been made, I will usually speak to the family, congratulate them, because it is important to return the joy of the pregnancy to the family, to remind them that they are having a baby, that they are not having a diagnosis. From there, we can talk about their surgeon options, talk about not only the surgeons on our team, but because we are in New York, in a major metropolitan area, there are other teams. And we can talk about who and what services are available. Soon you'll be hearing from our colleague, Dr. Lawrence Brecht, and he is the NAM provider on our team. NAM is nasoalveolar molding, and he has the greatest amount of experience in the world in providing nasoalveolar molding, and I introduced this concept to them and how it will reduce the number of surgeries in their child's lifetime if their child qualifies for nasoalveolar molding. We also talk about feeding and hearing and speech, because if the family has gone online, they often learn about the child being sent to the NICU and needing a feeding tube, and I assure them that in most cases the child will feed successfully with special bottles, and that they can take that baby home within 2 days, and often the child will not require NICU placement. They do very well with a good hospital that is prepared to welcome the baby as a healthy full-term baby, as most of our cleft babies are. We here at Lenox and within the Northwell system, that is the practice, to welcome babies as healthy full-term babies that have a cleft, rather than to treat the baby as a cleft. That is not our experience. We offer family support through our wonderful care providers, social work. We also have great support through our internet partners. There are different organizations. We rally around our families and network them to all appropriate feeding family support programs. Many of our families don't deliver here at Lenox, and so we work closely with the community hospitals. We encourage them, once the family has chosen a surgeon, we encourage the OB to reach out to our surgeons so that we can all be on the same page as far as delivery options, special bottles. We train the families in advance to use these special bottles so that we can all be on the same page. And then we're talking about the surgical timeline. So when meeting the surgeon, I'll often give the families a list of questions. There are so many different options. Is the surgeon trained to operate on the child that's had nasoalveolar molding? Or are they going to use same old surgical techniques that were developed prior to nasoalveolar molding? Do they use sutures that need to be removed or dissolved? What's their philosophy? Do they utilize their team? Do they not utilize their team? These are things that parents wouldn't necessarily think to ask a surgeon. Sorry. We explain to them about nasoalveolar molding and how it can be so beneficial over the lifetime of a child. As I said, we communicate with the birth hospital. We ask the families to learn about what the care is at the birth hospital. Do they automatically send the children to the NICU, and why do they automatically send children to the neonatal intensive care unit? Is it really a written policy, or is it some policy that someone thinks exists? Feeding. Some hospitals have a policy of immediately inserting a nasogastric feeding tube, when the fact is, in my 20-plus years working with children with clefts, feeding tubes are not necessary. If you have the right bottles and families are experienced and understand how the bottle works and what the problem is and what the problem is not, special bottles are a magic, and the baby can go home with the parents when mom is discharged. Hearing. Very often, babies with cleft palate are born with fluid in their middle ears, and parents need to understand why this might occur and how they'll need to have follow-up with an ear, nose, and throat doctor and an audiologist over the child's lifetime or until they're discharged from care. And it's important that they know that their newborn might not pass their newborn hearing screening, so that when they get the news that the child didn't pass, they don't automatically go to, oh my goodness, my child has a cleft and he or she is deaf as well. We don't want that happening. Speech therapy can begin the moment the diagnosis is made. We're teaching parents about good speech habits and bad speech habits. And this goes on continuously as the child is born through regular contact. When I'm in Dr. Breck's office during the nasoalveolar molding appointments, or when I'm in Dr. Bradley's office or in Dr. Warren's offices, we're always talking about speech and when sounds come in and what's typical sound acquisition and what we expect from our children with repaired cleft palates. Parental support, as I said earlier, is very important. During that prenatal consultation, we'll find out if there are family stressors or history of depression so that we can make sure that we're getting them referred to the proper sources. Having a first child is stressful, having a third child is stressful. And then if you have additional stressors like history of anxiety and depression, there needs to be appropriate support, and there are many support sources out there, both throughout this hospital system and throughout other wonderful organizations. The treatment timeline is also important. Some families want to know everything, what might happen in the next 20 years, and some families only want to know what's going to happen tomorrow. So it's important to find the right balance of what information you're going to provide. And I just want to say thank you for the opportunity to be member of the Next Gen Face, Cleft, and Craniofacial team. Thank you to Northwell Maternal Fetal Medicine. They've really embraced our team and have really added to our experience here. And thank you to all the other Northwell Lenox Hill Hospital members for supporting our team. Thank you.